This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in the department.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from World Neurosurgery 2026 titled Cerebellar Quadrangular Lobule Resection for Microsurgical Treatment of a Pontine Cavernous Malformation via the transmittal cerebellar peduncle approach.
This is a localized but highly technical case study, Alara. When we talk about brainstem cavernous malformations, or CMs, we are dealing with some of the most unforgiving real estate in the human body. The paper starts by reminding us of a fundamental epidemiological fact. The pons is the most common site for brainstem cavernous malformations.
Exactly, Dr. Aris. And because the pons is so densely packed with nuclei and white matter tracts, the surgical corridor we choose isn't just about convenience. It's about survival and functional preservation. This paper specifically focuses on the transmittal cerebellar peduncle, or MCP, approach, but it adds a specific surgical maneuver to increase exposure, the resection of the cerebellar quadrangular lobule.
Let's dive into that. For our residents listening, the MCP is often considered a safe entry zone for lateral pontine lesions, provided the lesion comes to the pile or ependymal surface. But why the quadrangular lobule resection? In this 2026 study, the authors argue that this specific resection facilitates the microsurgical treatment by expanding the surgical corridor.
Right. The quadrangular lobule is located on the superior surface of the cerebellar hemisphere. By resecting a portion of it, the surgeon gains a more direct, wider angle to the lateral aspect of the pons, where the MCP is located. According to the paper, this is particularly useful when the CM is situated in a way that a standard suboccipital or retrosigmoid approach might be too restrictive.
It's all about the line of sight in microsurgery. When we look at the pontine anatomy described in the paper, we're balancing on a knife's edge. You have the trigeminal nerve, cranial nerve 5, exiting ventrolaterally, and the facial and vestibulocochlear nerves, 7 and 8, at the cerebellopontine angle. The trans-MCP approach utilizes the space between these critical structures.
The authors emphasize that the resection of the quadrangular lobule allows for better visualization of the hemocydin-stained area of the pons, which is the classic surgical landmark for a cavernous malformation that has previously bled. Once they resected the lobule, they were able to perform a small corticectomy in the MCP to reach the malformation.
And that brings up a key point for the residents, the two-pile point principle. We want to reach the lesion where it is closest to the surface to minimize the crossing of healthy neurotissue. The paper notes that the trans-MCP approach, enhanced by this lobule resection, provides a direct path to the lateral pontine tegmentum.
Dr. Aris, looking at the technical nuances in the paper, they described the patient positioning in the craniotomy. They utilized a standard retrosigmoid approach as the foundation, but then moved into the quadrangular lobule resection to gain that extra few millimeters of superior to inferior trajectory.
It's a game of millimeters in the brainstem. The paper mentions that by removing that part of the cerebellum, you're essentially opening the curtains on the lateral pons. This reduces the need for excessive cerebellar retraction, which we know can lead to cerebellar swelling or even infarctions in some cases.
One thing I found interesting in their discussion was the focus on the surgical corridor's depth. By resecting the quadrangular lobule, they found they could achieve total resection of the CM with minimal manipulation of the surrounding pontine fibers. The paper reports that the microsurgical treatment was successful, specifically because the trans-MCP corridor was widened sufficiently to allow for two-handed microsurgical technique, dissecting the CM from the surrounding gliotic plane.
That's a crucial detail. You can't just suck out a cavernoma. You have to meticulously dissect the malformation from the hemocydin-stained brainstem parenchyma. If your corridor is too narrow, you're fighting your own instruments. The quadrangular lobule resection solves that spatial constraint.
For our practicing neurosurgeons, the paper also touches on the importance of intraoperative monitoring. During this trans-MCP approach, they monitored somatosensory evoked potentials, SSEPs, motor evoked potentials, MEPs, and brainstem auditory evoked responses, BERS. This was critical because the MCP is essentially the highway connecting the cerebellum to the rest of the brain.
Absolutely. If you're resecting part of the cerebellum and then traversing the MCP, you have to be certain you aren't compromising the patient's coordination or cranial nerve function. The study concludes that the cerebellar quadrangular lobule resection is a viable and effective modification to the trans-MCP approach for pontine CMs.
It's a great reminder that even established safe entry zones like the MCP can be optimized through targeted resection of non-eloquent cerebellar tissue to improve outcomes.
Well said, Alara. That's all the time we have for today's deep dive into the World Neurosurgery 2026 report, a fascinating look at how we can refine our approaches to the most common site of brainstem cavernous malformations.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.